So I just want to share with you some slides on this specific here about the use of TAVR CT. So remember, TAVR patients usually are some degree moderate to severe AS. We do not give nitroglycerin. They do have calcification in the valve, so a lot of times they also have concomitant CAC, coronary artery calcification. So just keep that in mind that the use of TAVR CTA to assess the coronary artery can be limited. However, I argue, especially with better machine, left main, proximal mid LAD, proximal mid RCA, to some degree proximal circ should be part of your routine assessment. Think about it as a rule-out test, i.e., if you are able to say there's no obstructive disease in these segments, that's enough to kind of reassure the operators that do not need to perform a CAT. However, when I see possible severe stenosis, I drop that in my impression saying absence of nitroglycerin can overestimate the degree of stenosis. So like that way, if you said possible severe stenosis like the LAD, they take that into consideration. So this is the hard CAT for the patient. You can appreciate the severe LAD, and this is the RCA was actually CTO. So again, do not use it much to confirm the obstruction more than to rule out, unless there's obvious CTO or more than 50% left main or more than 70% proximal mid segments. There is another case for TAVR if we have time. I think that one has an interesting finding. So let's go. So this is a systolic phase. By the way, we did not show you how we do the valve area planimetry. So just going to quickly show you. Always try to find the leaflet tips on the long axis and make sure you're really double obliqued. And you come to that area, you're not too down, because if you come down, you're going to overestimate the area. So you need to be at the leaflet tips. So here you can go ahead and do the planimetry. And the planimetry of the aortic valve, that like something we were talking about it last night with other faculty. Actually, it's really a strong tool if you have confidence in it. And we use it as if the valve area more than 1.3, this cannot be severe. A lot of times still moderate. But once you get to the 1.1, 1.2 on CT, it's similar to some degree of the 1 or even less on the echo. So just keep that in mind. So here I'm getting an area of 0.5. Maybe it's a little bit higher than this if I properly measure it. But definitely there's a severe AS just by the planimetry. And what I need you to pay attention, and take your time, maybe 45 seconds, 60 seconds, just to tell me what's something you can see. It's like an incidental finding, cardiac related. Exactly. So there's a retroaortic, good job, retroaortic course of the left main. Which sinus is coming from? Good job, okay. Now we talked about yesterday the features of the low versus high risk features. The different audience in the room, I think radiologists taught me, which I appreciate, to avoid the word malignant. I think cardiologists would freak out overnight if you say the patient has malignant, they are 70. This patient is like 80 or 75, and you tell them now patient has malignant course. So we try to use the high risk features versus low risk features. So we talked about the high risk features, the interarterial course, when it's above the pulmonic valve, i.e. between the aorta and the pulmonary artery, truly. If it's ostium, like being slit-like. So this is a retroaortic course. So there's no interarterial course to worry about. The ostium, there's no time to look, but it was fine. And even the degree of stenosis, a better phase in diastole did not show significant. But does this matter for this patient from structural standpoint? Why do you think the case being important? Good job. So exactly. So let's look at the course and understand the relationship of the course of the anomalous to the annulus. Remember, we talked about the annulus. So if I believe this is the annulus, and it's not bad, roughly speaking, if we think this is the annulus, where is the minimal dimension versus the maximum dimension? So this is going to be your maximum dimension, likely, and this is your minimal dimension. So if you use a SAPIEN valve, the SAPIEN is a balloon expandable valve, the annulus is never almost like a circle, right? It's more elliptical. So when they deploy it with the balloon, what's going to happen? The minimal dimension is going to expand more. And what's opposing the minimal dimension here? So when you have a retroaortic course artery at the level of the annulus, mostly specifically facing the short axis dimension or the shorter dimension, it can be an issue during the SAPIEN or the balloon expandable valve. And this is one of the times it does matter. So this patient, we talked to the structural team that we prefer to use maybe evolute or self-expandable valve. So this is like, you're not going to encounter it often, but this is one of the times the retroaortic course matters for the structural cases. Any question about this case? And whoever solves the puzzle will go for first for lunch. So let's go ahead, put it as cardiac. And I need someone to tell me what's wrong with the Watchman. All right, folks. So to Dr. Rodriguez's lecture in the morning, is there contrast coming into the left atrial appendage? Yes. What is the mechanism? It could be, so that's three differential, right? You mentioned the peri-device leak, incomplete endothelialization, or uncovered lobe, right? I think this is the biggest lobe I've seen in the past 6 months. So see how huge this lobe is? You see how even like beautiful 3D volume rendered by the Recon. Look at this. Like you walk in from outside the room and you're like, what is going on with the appendage? Look at how the Watchman is sitting and the whole, you see my cursor on the 3D volume rendered? This all appendage is not even included in the device. So there's a huge uncovered lobe. And the structural folks or the structural images in this room will talk about sometime how we cover these with plugs or so. So this is one of the cases that's actually a large uncovered lobe. I think it was like 10 by 9 millimeter or something. You can measure it here. Like if I go back and forth, and you can appreciate how big it is here on the short axis. This is all uncovered lobe. So we talked to the team, and the plan was to attempt with some plugs because this is not in any form covered. So I'm just gonna show you one slide here about these cases where we encounter the uncovered lobe. So again, this is like the 3D volume rendered images. You can appreciate how the appendage is not well covering. And it's really tricky sometimes on the TE. You can appreciate here, this is the uncovered lobe, now you see it, but sometimes when it's so large, you don't even see flow acceleration, so to kind of assess for peri-device leaks. So just be aware of that. By the way, this was done for aortic regurgitation. Unfortunately, the phase that was saved is systolic phase. But I want to just point out to you, when we assess the aortic valve, go to the diastole and understand the valve coaptation. So this is during diastole. You see the phase here. There's a large coaptation gap. So anytime you see that, you measure it on the CT. I go by the 0.23, 0.25 and above to be some degree significant. So if you see a big gap in the aortic leaflets and you know you're at the leaflet tips, you're not down, you have to be at the leaflet tips. Anything above 0.23 to some degree, I think it's at least some moderate, if not more. And we did an MRI for this patient, it was severe. So anyway, so again, residual patency, look for the 3 differential and try to understand the mechanism more than just like, reporting there's a peri-device leak, and talk to the operators if there's any potential like, percutaneous like plugs or cores or what so. I'm gonna stop here and thank you all.